Good afternoon. My name is Patrick Kupelian, VP of Medical Affairs at Varian. And first, I would like to apologize for not being able to be there in person at the symposium today. So what I would like to cover today is the current clinical evidence around proton therapy, introduce the concept of FLASH and the results of it today. Clinical evidence. By clinical evidence, I don't mean dosimetric improvement. We know that in a lot of contexts, proton therapy in its different forms can be dosimetrically superior. In the clinical context, however, where we expect the benefit from proton therapy to be is around decreased radiation dose exposure, which means less toxicity, less second cancers, and there are a number of sites where this has been laid out. If we look at the indications for proton therapy as described by ASTRO at least, you can see that it's not around necessarily disease site, it's more the context in which proton therapy is considered to be reasonable. A target volume in close proximity to critical structures requiring a steep dose gradient, a more homogeneous delivery needed to avoid hotspots, a situation where photon technique would be too toxic by looking at the overall integral dose. Also in the context of prior radiation, where again we need to decrease overall radiation dose. So where there are clear indications today is in pediatric tumors, ocular tumors, skull-based spine tumors, some liver cancers, CNS cancers, thymomas, possibly in advanced or unresectable head and neck cancers, some sarcomas, and obviously the re-irradiation context. More common indications or possible indications are listed down there, but these are, at least by ASTRO, considered areas where patients are better off served being on clinical trials or registries. So let's look at the clear indications. So I'm going to cover some of the pediatric cancers, then some common indications and prostate. So pediatric cancers. Actually, a lot of the applications have been in the context of pediatric CNS tumors, which are the most common ones, sarcomas and things like neuroblastomas. And again, where you see potential benefit is in decrease in second cancers. In the brain context, much less neurocognitive dysfunction, avoiding growth and skeletal problems, avoiding cardiac problems, and overall radiation dose exposure. So this is a good overall review of the clinical effectiveness of proton therapy in children. This is out of Europe. So if you want a quick refresh, this is this one. But overall, the bottom line is that there are no randomized studies. And overall, survival and tumor control have been comparable to photon therapy. However, the advantage comes in seeing reduced incidence of severe and acute late toxicities. However, even in the best of series, best of centers, there's still not very long-term follow-up to look at, let's say, 30 or 40-year second cancer rates, etc. However, it is clear that in CNS tumors, there's reduced toxicity in the form of less endocrine, neurological, IQ, quality of life problems. As just an example of what you can find in the literature, medulloblastoma is obviously a poster child for the application of proton therapy. But you can see from this series, about 60 patients, where they observed no late toxicity in the heart, lungs, digestive tract, no second cancers, and the IQ in proton patients decreasing less than in equivalent patients treated with photon therapy. So this is the type of studies you would expect to find in the Now, specifically for second cancers, the only reasonable study out there, very hard topic to study, is from Mass General, where they looked at not necessarily only in pediatric patients, but in a cohort of patients treated with proton therapy. And they matched these patients with patients, similar patients treated with photon therapy in their clinic, with a reasonable follow-up, what they observed was about a 5%, second cancer rate in proton patients versus in about 7.5 to 8%. So that is a 50% less chance of second cancers in these patients. But this is a very hard topic to study, since you don't necessarily even know if the second cancers are directly related to the radiation therapy delivered or the proton therapy delivered, or if it's second cancer happening for some reason. And neck cancers. Well, the area where proton therapy has been utilized a lot and seems to be actually superior, clearly superior, is in skull-based tumors, chondrosarcomas, and there are a couple of series from Mass General and PSI in Switzerland showing very good local control. Very good local control in both chordomas and sarcomas. So these diagnoses are pretty clear dosimetrically and by clinical results where there's clear superiority for proton therapy. Then you get into nasal cavity sinus tumors. The best evidence here is a meta-analysis from the Mayo Clinic. The reference is there, and they reported that they believe that there's a higher, there are better results in these patients treated with proton therapy with respect to survival and control, and not necessarily just in the toxicity range. So beyond that, if you look at things like oropharyngeal cancers or unilateral head and neck cancers, a lot of good data, but this is mostly now in the domain of decreased toxicity. So MD Anderson reported improved quality of life in IMPT patients versus IMRT in oropharyngeal cancers, and also around this issue of less altered taste, less feeding tube dependency at about a year after treatment. So again, short to long-term toxicity, long-term meaning within 2 to 3 years after treatment. Unilateral head and neck cancers is actually pretty interesting. Memorial has published on this, where they report that it's kind of like treating with electrons. You're not exposing the rest of the anatomy, the neck anatomy, to high doses. So they reported that mucositis, altered taste, nausea, vomiting were better with proton therapy compared to their photon experience. Let's move on to CNS. There's some suggestion, at least from Japan, that maybe in high-grade gliomas there's better control, but it's hard to judge. The results have been pretty good with reasonably aggressive doses that, as you can see, delivered in Japan. And in meningioma, both Mass General and PSI have actually very good survival and local control rates. With respect to less toxicity, PEN in a small number of patients with low-grade gliomas and meningiomas, in patients receiving about 54 gray, they reported no severe toxicity, just minor acute toxicities. And same thing with MGH, where they looked at grade 2 gliomas receiving 54 gray, where they documented there was not much change in cognitive function or quality of life changes, which is actually a pretty significant endpoint in patients. Moving to the eye cancers, liver is an interesting site, and there are a couple of studies coming from Asia, from Japan and Korea, where in Japan they've actually pushed the dose is pretty high in hyperfractionated form and demonstrated actually pretty good local control and survival rates in these patients with primary liver cancers. In Korea, there was a dose escalation study going to actually pretty high doses. You can see there 72 grain 24 fractions, where they observed really good complete response rates with these doses going higher and higher. But there's a good meta-analysis published. You can see the reference down there, where overall there's this belief, without any randomized studies at this point in time, that that outcomes could be better with particle therapy, specifically proton therapy compared to photon therapy in liver cancer patients with respect to survival, progression-free survival, and control. Esophageal cancer, as a GI cancer, is another interesting site. This is not an easy disease to treat, as you know. Lots of toxicity associated with routine treatment of these patients. But again, the advantage here has to come not necessarily from increased doses or expecting better survival. However, it's mostly decreasing complications. So one context is chemoradiation following surgery. And from MD Anderson, there's a series showing less pulmonary complications with proton therapy. And then in patients treated definitively with chemoradiation with proton therapy, MD Anderson reported better, actually, even survival and control rates compared to their historical IMRT patients. Radiation. Intuitively, radiation would be a great context for therapy, given the lower integrative doses delivered with proton therapy. And this is a good review of the topic, recently published a couple of years ago. And this is essentially a digest of that paper. So in recurrent melanomas, uveal melanomas, actually pretty good results, local control being around 30% for these recurrent patients, which is actually pretty good, with an eye retention rate of about 50%. And adult CNS tumors in the re-radiation settings, not much significant grade 3 effects with pretty high doses being delivered with proton therapy, but this is a heterogeneous group of patients being treated in the re-radiation context, so it's hard to make strong statements regarding very long-term follow-up. But for these patients, this is actually a very good option. In head and neck cancers and recurrent head and neck cancers with re-radiation doses in the 60 gray range, actually you can see there actually reasonable local control rates around 70%. With acceptable toxicities in this context. 5% of patients getting grade 4 skin toxicities. In this very hard context, most of the time we treat anyway, toxicities are expected, but this is actually a pretty good profile compared to photon therapy. Lung re-radiation, MD Anderson reported re-radiation with a median dose of about 66 gray. 50% local control, local regional control, 50% 1-year survival, and with grade esophagitis, which is acceptable around 10%, and a grade 3 pneumonitis rate about 20%, which in this re-radiation context, again, with patients not having much options, these are pretty good results. Okay. In primary lung cancers, number of series for early stage lung cancers where the results are actually pretty good. No doubt about it, proton therapy works as well as photon therapy in controlling early lung cancers. So there's a meta-analysis published a couple of years ago of a large number of SBRT series and 9 proton therapy reports on the topic. Essentially, survival, progression-free survival was not statistically significant. In this meta-analysis, however, they mentioned that in their analysis, proton therapy had a more favorable local control profile. However, in locally advanced cancer, where ideally we would want to make more progress, the disappointment was in the prospective trial by MD Anderson looking at proton therapy versus IMRT with concurrent chemotherapy. Patients received not the same dose, but somewhere between 66 and 74 gray, which by conventional fractionation today we know is probably on the high side. And in this study, it's worth mentioning that they expected a 15% pneumonitis rate in the IMRT group and a 5% pneumonitis rate in the proton therapy group, which 5% is actually pretty low. Interestingly, what they noticed is a grade 3 pneumonitis of about 6.5% in the IMRT patients, much better than expected, and local failure being about the same. So this trial fundamentally was negative. There was a lot of critique about that this was not an IMPT series, the standard radiation doses were too high maybe, et cetera, but fundamentally it was a negative study. I would have to think that, different approaches, maybe with tighter margins and more hypofractionated approaches, we should be able to get better results. So it's not that proton therapy doesn't work in lung cancers. We know that it does, looking at especially the results with early stage lung cancers. It's just that probably technique-wise, scheduling-wise, we could do better. Prostate cancer. Area of controversy. The bottom line is that it's a mixed picture. There is no clear data showing the benefit of proton therapy compared to external beam or brachytherapy. And ASTRO today recommends that if prostate cancer patients are to be treated on proton therapy, they are enrolled on clinical trials or registries. However, if you look at the literature, it hasn't been consistent. At UPenn, they published a series of patients where there were essentially no differences between IMRT and proton therapy. Large SEER database analysis, which is not a very complete database with respect to details of treatment, but roughly looking at IMRT versus proton therapy patients, they reported proton therapy same and maybe even worse toxicity compared to IMRT with respect to prostate cancer. On the other hand, MD Anderson published a series of patients, a decent number of patients, around 700 proton patients, and over 3,000 IMRT patients, where they reported less urinary toxicity, less erectile dysfunction with proton therapy, but maybe a little bit slightly higher bowel toxicity rate with proton therapy. So again, a very mixed picture with prostate cancer. However, these have been mostly standard, conventionally fractionated schedules, and maybe we could do also better with shrinking margins, et cetera, et cetera. Now, in the broader toxicity reduction top, this is a paper that recently got a lot of visibility out of UPenn, where they looked at not necessarily a single diagnosis, but a number of locally advanced cancers treated with concurrent chemoradiotherapy, and looked at the mostly the toxicity between proton and photon therapy. And what this was a non-randomized study, but over 1,400, almost 1,500 adult patients. About 400 patients were treated with protons, about 1,000 with photons. And what they reported is, if you look at again, in this group of patients with a number of diagnoses, that the grade 3 and above adverse events at 90 days was less with proton therapy. There was less grade 2 plus adverse events at 90 days. So the readmission rates or the management of the toxicities in these patients in the first 3 months after therapy was much more favorable in the proton context. There was also less decline in performance status during the radiation. Obviously, no difference in disease-free or overall survival. So, comparative effectiveness-wise, proton therapy had a much better profile, at least in the period of time that they analyzed their data, which was within the first year of therapy. So, a lot of in this paper. Now, So that's the clinical evidence today. But this is essentially fundamentally the clinical experience with proton therapy using techniques and dose schedules that have been used with photon therapy, with some exceptions, but in general that was the case. But it doesn't mean that we've tapped into all the potential of proton therapy. So there are future approaches, future applications, improvements that we expect on the proton therapy side that could change this perspective. If we had adapted, if we did more radiosurgery type of approaches with different techniques, if we implemented techniques such as arc therapy, how much better could proton therapy be? Imaging is a big deal, so if you look at the iterative cone beam CTs that we obtain on different platforms on varying machines, you can see that we're getting actually very good images where you can start thinking about shaping margins, adaptive processes, etc., and that changes the toxicity profile. So on top of less integral dose, if we can make these doses more compact, more conformal, on the basis of better imaging, then maybe there would be it would start to look different. And then there's FLASH as a potential area of improvement. So FLASH, let's define FLASH first of all for the participants who haven't heard about that. So if this is now, we're defining it as ultra high dose external beam delivery. So it's high dose external beam delivery in less than 1 second in 1 to 3 treatments. So if you look at the current dose rates that we utilize, and this is now shown in centigrade per minute, a Clinac machine will be about 400 centigrade a minute. A true beam in certain modes will go up to 2400 centigrade per minute. The current proton beam device from Varian, the Pro Beam, would go to 10,000 centigrade a minute. And when we're talking about FLASH, we're talking about much higher dose rates. So if we translate that to per second, that'd be looking at ranges of 40 gray a second up to over 120 gray a second. So that's what's being defined as FLASH. 40 gray a second is probably at the lower end of where we would expect FLASH. 100 gray a second is where we're probably defining FLASH. This is a very hot topic in cancer treatment today. Number of publications, presentations, this has accelerated dramatically over the past couple of years, and there was even a Green Journal. What's the bottom line on FLASH? Is that FLASH spares normal tissues. And this was first observed in mice around maybe 6 years ago. This is from a publication, the very first one describing FLASH in the modern era from Institut Curie in Paris, where they looked at normal tissue lung fibrosis specifically in mice, treated with an experimental setup with electrons running on FLASH for these animal experiments. And you can see there's significantly more fibrosis with a single fraction of 70 gray delivered with a standard dose rate compared to FLASH. So if in this first communication, they showed that there was not much apparent damage in these lungs. And in a group from Lausanne repeated similar experiments, but this is the one that was really interested in mini pigs, where they looked at skin, and you can see on the left side, conventionally treated pigs versus FLASH, where they delivered large doses, single fraction doses of 34 gray, up to 34 gray. And then, looking at the skin effect, you can see clear areas of necrosis in the conventionally treated animals versus the FLASH treated animals. So looking at it under a microscope, you can see there was not much infiltrates, etc., etc. So the control was pre-flash treated animals. In spontaneous tumors, this was again a study done at Lausanne, where they took cats with nasal cavity tumors, spontaneous tumors, and delivered doses that went from about 25 up to 41 gray single fraction in these animals around the nasal cavity. And they reported actually pretty good results. So you can see, as other than loss of hair, these animals have actually a control rate, and no significant long-term toxicity. So very impressive for these massive doses delivered. So at Varian now, we realize that to deliver FLASH in a clinical setting for a variety of tumors and disease sites in at depth, especially in the body, proton therapy is the perfect platform to actually start testing FLASH, because we can go to high dose rates on current proton therapy machines, capable to actually get the FLASH effect. So not only the effort now at Varian is actually to develop the newer platforms that are less costly, smaller, more compact, etc., more treatment planning, capabilities of different kinds, but also exploring what FLASH could give us as a non-invasive single fraction or few fraction type of delivery with novel biology, so to say. So at Varian, this is mostly the timeline that we followed. The first paper that was published around 2014 by Favedon sparked a lot of interest, and we filed a number of patents, and we started doing our in-house proton flash experiments about 3 years ago. So this is what I'm going to cover. So for you who don't realize that at Varian now in California, we have translational labs looking at different aspects of radiation. And so this work that I'm going to show now has been done in collaboration with our academic partners at University of Maryland in Cincinnati, where the actual animals were irradiated and a lot of the analysis of tissues have been done. So this is the first proton flash experiments done, where we took about 400 mice and irradiated the lungs to doses like between 15 gray and 20 gray, single fraction, and looked at survival in these animals, fibrosis in the lungs, and different molecular characteristics. So looking at survival, there was an improvement in survival in in animals treated with FLASH, and also a reduction in dermatitis. That was pretty significant. First of all the severe reactions were all in the conventionally treated animals, but in the FLASH treated animals, there was a 50% reduction in dermatitis. Where we also saw with proton therapy, with FLASH therapy, a significant improvement was in lung fibrosis, where there was over a 20% improvement in lung fibrosis, grading the fibrosis by an independent pathologist between FLASH protons and conventional protons. But just a quick comment here, if you look at the initial experiments with electrons, they compared pretty low dose rates to FLASH dose rates. Here, what we did is compared proton conventional dose rates, which are pretty high. Like I showed you, could go, it's around 10,000 centigrade per minute, to a FLASH which was 40 gray a second. This is not as wide a range of dose rates that was compared. Maybe the impact that they saw with electrons was compared to with conventional dose rates. are not were expected to be larger than we saw here, but still, this type of difference is significant for the fraction treatments. But where it gets even more interesting is when we looked at the differential gene expression at 24 hours of radiation in normal lung, treated to 15 gray. So what we looked at are the genes that were overexpressed or underexpressed, upregulated or downregulated in the normal lung in these animals treated either with conventional dose rates with protons or flash protons. So in the circles here, what you have in white are the upregulated genes and black the downregulated genes, conventional versus flash dose rates. And it's clear that on the conventional dose rate side, the number of upregulated and downregulated genes the numbers are very large. Versus, look at what happens on the flash side. There's some overlap, but there are also different genes upregulated and downregulated. So whatever is happening in tissues, at least normal lung tissues, is dramatically different between flash and protons. And without dwelling into this too much, looking at the different profiles here, what we observed was that there was clearly downregulation of inflammatory and apoptotic pathways compared to conventional dose rates, meaning that this is happening because of inflammation being less and apoptosis being less provoked by flash dose rate. Now that was in normal tissues, but this would not be of any interest, though, if there was also sparing in tumor. So with flash, those over with protons, the first experiments that we did were in animals who had lung cancer. So what we did is treat them with flash versus conventional, and you can see here, looking at tumor volume as a proxy of control, that flash and conventionally treated animals, the tumors were controlled as well. So there was no sparing of tumors. These were lung cancers with flash. So again, you spare normal tissues, no impact on tumors, so the therapeutic window was significant. And quickly, just to show that, even looking at the morphology of cells treated with conventional versus flash dose rates, you have here in red with the M-cherry staining, you're looking at the actual tumor cells in these sections. And you can see that, there's essentially between the conventional and flash, you see the same number of cells around. You don't see sparing with flash, and maybe even a little bit more kill with flash. There are less of the red dots in the flash group. And then the other thing we observed is infiltration of immune cells in especially the core of these tumors. So if you look at again control, conventional dose rates and flash dose rates, and the staining here is for CD3 T cells. There was more infiltration in tumors treated with flash compared to controls or conventional. And this is CD8 cells, same thing. See more infiltration at the core of the tumor with flash versus conventional, meaning that if there was some mechanism by which the tumors also were being spared, maybe the presence of immune cells much more predominantly in the middle of the tumor contributes to more tumor cell kill. Therefore, at least the same control, better control that we're seeing with flash. So all this is preliminary, but very, very exciting. It's very consistent with what other people have observed. So as a summary, flash is a hot topic in radiotherapy because of normal tissue sparing and no impact on tumors. Nearly all data today is in small animals in vivo. There's some large animal experiments like the ones that I showed you with the cats and pigs, It's only one human patient treated for a skin lesion with an experimental flash setup with electrons, so not applicable to the rest of the body, single human in Lausanne with good results. So this is now a major initiative, definitely at Varian. We are funding projects. We have a FLASH consortium, multiple technical research collaborations, and we also have Varian clinical trials in preparation. So with that, I thank you, and I'm gonna, I think, pass it to Bill Hansen to go over what our activities are around FLASH. Otherwise, again, I apologize for not being there, and have a great rest of the meeting. Thank you. And one more thing, I would be happy to take questions by email. So if you have access to my email, feel free to contact me. Take care. Thank you.